Hello, everyone, and welcome to our webinar, Make Your Wishes Known with Advanced Care Planning. My name is Lauren Blair, and I'm the Provider and Community Relations Manager at Coastal Hospice. Welcome to our Caregiver Academy. We are excited that you're joining us today. We have colleagues from Tidal Health, the Holly Center, Worcester Adult Medical Day Services, MAC, and many, many more. Thank you for being here with us today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to address or help with any technical issues. I want to thank you in advance for your patience should we have any. I'll also discuss the program evaluation at the end of this webinar. Please use the chat feature to ask questions and communicate throughout the webinar. Further instructions are located in the chat box. On Saturday, April 16th, we celebrated National Healthcare Decisions Day, and today we are excited to present more information on this important topic to you. I had the honor of moderating this webinar today and have invited two experts in the field of advanced care planning. Gigi Pierce is a primary care nurse care coordinator for population health at Tidal Health. Prior to that, she worked at Johns Hopkins Hospital in Baltimore, Maryland. Before that, she spent 17 years providing critical care at Tidal Health and has had experience with working with the palliative care team. Most recently, Gigi was part of an Advance Directive work group to educate and promote end-of-life planning. She provides a webinar on Advance Directives and was a guest on Tidal Health podcast for Advance Directives. In addition, she led a chronic disease self-management program on living well with cancer and living well with chronic pain. Welcome, Gigi.
Thank you.
John Tyler is the manager of pastoral care at Tidal Health. John has been with Tidal Health for 7 years, 5 years as hospital and palliative care chaplain, and the last 2 years as manager. He is a board certified chaplain and currently pursuing his master in theology and chaplaincy. He will be receiving his degree in May of 2022. His specialties include palliative care certification, advanced care planning facilitator, and biomedical ethics. Welcome, John.
Good to be here.
Welcome again, Gigi and John. We're so excited and happy to have you here with us today. Gigi, I'm going to turn it over to you.
Thank you. I'm excited to be here. Like I said, I spent many years as an ICU nurse, and although we try to get everyone better in the intensive care unit, not everyone gets better. So we do have to deal with a lot of end-of-life issues in the intensive care unit. And that really brought me to the forefront of trying to explain to patients and family members how important this work is. And it's done way before anyone gets critically ill. So without further ado, I will start presenting on advanced care planning. So the goals of our presentation is to gain empowerment to start these conversations regarding end of life. Like I said, they start way before you get critically ill, and they're not easy conversations. So we also want to explore why you need to plan for end of life using advanced directives. To learn the difference between advanced directives, living wills, medical power of attorney, and a MOLST form, which is a medical order for life-sustaining treatments. I'd like for you to learn how to fill out these forms to reflect your wishes, to learn how to make changes in these documents if you change your mind about any of these decisions, and to provide support and resources for how you can make your preferences known for life support nearing the end of life. And for you to all recognize that illnesses, suffering, disability, aging, and dying are all natural and normal parts of life.
So tell us, Gigi, what is advanced care planning?
So advanced care planning is learning about the different types of healthcare decisions that may need to be made as you age and as your health declines. You want to clarify your goals of care with your healthcare providers based on your needs, your goals, and your values. Like financial and estate planning, end of life planning begins long before someone is faced with a life-limiting illness, and it's part of a life well lived. So they do research on, everything, but one of the things that they researched was what's most important to people nearing the end of life. And most people want to make sure that their family is not financially burdened by their care. Number 2 was being comfortable and without pain. Number 3 was making sure the family is not burdened by tough decisions. And by doing your advanced care planning ahead of time, they won't be burdened by by tough decisions. Equally as important was having loved ones around me nearing the end of life. And number 4 was, again, being able to pay for the care that you need. And all of this takes proper planning. So what's most important to you as you near the end of your life? So you want to have a conversation about goals of care. This helps patients and families with serious illnesses clarify their goals and values regarding end-of-life care. Your providers want to respect your values by caring for you in a way that reflects your hopes, values, and expectations.
And who should you talk to about goals of care?
So you want to talk to the person who is named as your advanced care planning proxy, your close family members, your providers, and anyone who you deem important enough to help you make these major decisions,
Great.
Including your chaplain, pastor, or spiritual leader.
Great, thank you.
So how do you explore goals of care with your provider? You're going to ask your provider about your diagnosis and your prognosis and what to expect as your health changes or declines. And you want to go over your priorities. What is most important to you? Like we said before, hopes, worries, expectations. What's most important to you at this present moment? And then you're going to ask for recommendations, review any treatments that you would or not want to do based on past experience with either yourself, your own health, or other family members or friends. And then what treatment or plans will help you meet your goals.
So this is a good time to kind of talk to your provider and maybe repeat back to them what you understand about your diagnosis. Is that right?
Exactly. Sometimes there's not a lot of time that you have with your provider when you do get to meet with them, but it's important for your provider to know that what you don't understand or do understand so that they can clarify any miscommunication.
Absolutely, because you may hear kind of one piece of the diagnosis or prognosis, but not the other, and may not understand all of it. So it's a great idea to repeat back what we know and understand.
Correct. For example, there's a patient of mine who he's getting palliative chemotherapy, but he didn't understand that what that means is that there is no cure, that this is just for comfort. And I think that happens more times than we realize.
Absolutely. Absolutely. So how do you start these difficult conversations?
So these conversations, like I said, are meant to be done before someone gets critically ill. You want to have these conversations with your family, your closest, confidants, and especially if you have a chronic disease like congestive heart failure, chronic obstructive pulmonary disease, or COPD. If you have diabetes that progresses, diabetes affects all of your organs, and then chronic kidney disease, and neurological disorders like dementia or Parkinson's. If you have any of these or multiple chronic diseases, it's always good to start talking about your plans. And then you really want to know what your future looks like in regards to your health and about your current situation. And you want your family members to really know what's going on with your health as well. I think that's important. And most of us make better decisions about our health care when we understand what's going on. So clarification of any communication is always best between you and your providers.
Sure.
So continuing the conversation. Sometimes we tell people start these conversations at Thanksgiving or Christmas dinner. Maybe that's not the best time, but it could come up if there's been a family member or friend that's been hospitalized or had a death, and this conversation comes up. That's a really good time to start talking about what you would or would not want based on these experiences. And you want to explore your worries and your fears and your concerns. Are there certain things that you want to do before you die? Your bucket list. And this can alter your treatment plans. So when your health declines and you'd want to decide when would it be okay to shift your focus from aggressive treatments to a focus on comfort and quality of life. And that's going to be different for everyone. So do you value being independent, or would it be okay for you to live in a nursing home nearing the end of life? I have many patients who say, I've lived in this house for so many years and I'm going to die in this house, and they're not going to a facility, and that's fine. And other patients, that's where they're going to spend the rest of the remaining days, and they're okay with that. So it's very preferential. And are there kinds of treatments you would want or not want based on, your experience and how you're feeling right now? Would you want to be kept alive on life support, even if you're unable to interact with your family and friends? I mean, some people absolutely would not want that, and some people would say that is still acceptable quality of life. So like I said, everyone has their own ideas and values, and there are so many choices to consider.
And there's no wrong answer, right? This is just based on your wishes and your preferences.
Correct. And you want to have a little bit of control over what's going to happen to you. It's your body, it's your decisions, your choices. And the doctors don't always know everything about what you would want. So it's good to communicate.
Absolutely.
So there's many benefits to advanced care planning. Your treatment will consist of what you wish for. Your quality of life and quality of care would be improved. You have improved satisfaction with your care overall. There's improved end-of-life care, reduced physical and psychological distress in the last days of life. So when we are able to meet your expectations, you get, better satisfaction.
Absolutely. I have a question that popped up in the chat box, GT, from Penelope. Penelope asked, what is the appropriate age to begin completing advanced care planning forms?
So that's a good question. Unfortunately, when there's young people that are in bad car accidents and they wind up in the intensive care unit, it's never too early to start planning and talking about this. And I think 18 is probably a good time. Advanced care planning really came to fruition from a couple of chronically ill patients, young women in their 20s, who had an event and wound up with feeding tubes, and they lived many, many years in a nursing facility, and there was fighting amongst the family, the parents versus the husband, as to the best care for this patient. So, this kind of really we don't really want that to happen again. So it's best for these conversations to be done as early as possible. And of course, your feelings could change as to what your care would be done over time.
Absolutely.
So advanced care planning is used to make your wishes known so your family and healthcare providers can make these decisions about your treatments in case you are unable to make decisions for yourself. You're unable to communicate to make your preferences known. So that's only these documents come into play only at that time. As long as you can voice your opinions and your decisions and you're deemed competent, you're able to make decisions regarding your care. Many of us, about 1 out of 10, are going to be diagnosed with dementia someday. This complicates advanced care planning. When someone is deemed incompetent, they can no longer fill out these forms, and it's up to the next of kin to make all these decisions. And sometimes, like many years ago when I was an ICU nurse, families never talked about this. And it was kind of enlightening that, we all know it's going to happen and we all know we're going to age, but nobody ever talked about it. And I thought that was, a lack of communication on the healthcare team, and, it needed to be in the forefront. So I'm glad we're doing this. And this can be burdensome. If your loved one was in this ICU bed and you had to make decisions and you never talked about anything, that's a lot of stress and burden on family members. And some family members, they don't agree on where to go to dinner, or what to have for dinner. So making these big decisions could be very hard for some families.
Absolutely. It's traumatic. It's causes some conflict between families. So it's just so important to get your decisions out there early.
Exactly. So a lot of people do advanced care planning in their living will, and it's completed by a lawyer as part of their financial and estate planning. And a lot of patients that I ask, say, do you have advanced directives? They say, yo, it's in my lockbox and at the bank, it's in a drawer at home. Those documents need to be in your primary care office chart system or the hospital system that you would likely use if needed. And also a copy should be given to your medical power of attorney who you choose, so that it's available when you do need it or if you ever need it. And not everybody is going to need these, but it's always best to plan. And this is a simple one. It just says, if I am deemed medically confirmed that there's no reasonable hope for my recovery, I would want comfort care. I don't want prolonged artificial means to keep me alive. And I want my wishes to be honored by my family and my physicians. So this is the simplest form of a living will. The Maryland, each state has their own documentation. So we'll go over that as well.
Thank you.
And John will take over.
Hello. So we're going to go over the Maryland Advance Directive form. The steps of an Advance Directive are selecting your healthcare agent, your medical power of attorney, and possibly a backup agent. Your agent will make the healthcare decisions for you in accordance with what your agent determines to be in your best interest. Your agent will consider your personal values and beliefs along with the help of healthcare professionals. Also, you decide what power or limitations you want for your agent and how your agent is to decide on specific issues or situations. There's an optional for there to be people that your agent should consult. Say if you know somebody in the medical field and you want your agent to consult that person about certain issues, then they can do so, but their consultant will have no decision-making powers. Effectiveness of the agent's authority. When does your agent's power start? This usually happens when you cannot speak for yourself. Making your treatment preferences known if you are in a terminal condition, a persistent vegetative state, or an end-stage condition. And then there is a signature and witness page. So selecting a medical healthcare agent or medical power of attorney or healthcare proxy, it's named different things. Naming somebody that you trust and you can that will abide by your wishes according to your goals, your preferences, your values, and how you may have handled other major decisions in the past. Sort of if you've had they've had a loved one died in the past, how did they handle that situation? What did they want? What did they say? Oh, I wouldn't want that to happen to me. Things like that. Your agent will make decisions based on what is in your best interest, considering benefits, burdens, and risk of the choices presented by providers. The very first advanced directive that I completed with a patient 7 years ago was a gentleman that was in the hospital. He was in the hospital bed. His wife was at the end of the bed. And he said, I asked him, I said, who would you want to make decisions for you in the event that you could not? And he said, well, not her, because she's not making good decisions now. And she got up, she smacked him across the face and left the room. Well, he chose his sister and not his wife. And a lot of times we think that, it should be a family member or whatever, but sometimes the emotions, and we know our family members, if they get too emotional, then they may not make the best decision, depending on how they feel and their emotions at that time.
Sure.
So but then you need to have a conversation with your agent. And that's just as important as filling out the legal document in itself.
So what if I were to change my mind, if I filled out my advance directives and named someone a healthcare agent, and then maybe we had a falling out and a year later I wanted to change it, is that okay?
Yes, it is. And the way that you change it is you just fill out a new form.
Okay,
And the date supersedes the other dates, and the latest one is what they will go by.
great, easy enough. So what if my agent is unavailable to make decisions for me?
Well, if your agent is unavailable, we suggest that you elect a backup agent. You know, again, somebody you trust, somebody that knows everything. But in case they can't get a hold of your primary agent, then your backup agent will have to make those decisions. And like I said, you may also name people that your agent should consult when major decisions need to be made. And, you know, this could be anybody. But, you know, in the healthcare field, a lot of healthcare workers, you know, choose other healthcare workers and everything. So it's very important, you know, just to be informed. And that's what the consultant will do.
Right.
So my agent's power is in effect. There are two options here. There's one immediately after signing the document, and you still have the say as long as you're able to speak for yourself and have competency, or when you have lost the ability to make decisions on your own. Now, on the form, it has that two doctors have to agree that you cannot make decisions on your own. That's the second choice. The first choice is immediately. So as long as you can speak for yourself, if you want to, okay? Sometimes people can still speak for themselves, but they don't want to. They want their agent to go ahead and make those decisions for them. Choosing whether your agent has flexibility in making decisions for you. You know, this is, again, the Maryland form. This is important because a lot of people think that if they fill this form out, then, you know, they're kind of stuck. So this gives the flexibility or not having flexibility. It says my stated preferences are meant to guide whoever is making decisions on my behalf and my healthcare providers. I authorize them to be flexible in applying these statements if they feel that doing so would be in my best interest. You know, and say that you became unconscious and the doctor steps in and says, well, I think that we can get them back to talking to us if we do this, okay? So it wouldn't do anything to correct the underlying problem, but it may get them to a place where they can be talking to us again in that. Well, there's a flexibility there for your agent to say, yes, go ahead and do that, okay? Or it says, I want whoever is making decisions on my behalf or my healthcare providers to follow my stated preferences exactly as written, even if they think that some alternative is better. And a lot of times you have cancer patients or whatever that are just tired. They're tired of the treatment. They're tired of the poking and prodding. And so they will sometimes choose just to do as I have written. And you know, it's your choice. You can choose one or the other, but the flexibility is there so that it's not just set in stone that this is what's going to happen.
Sure. Mm-hmm.
What if I feel like my agent knows what is best for me and I feel confident that they would know what to do in any situation? Well, part 2 of the Advance Directive, the living will, can be left blank, okay? You don't have to make any of those choices if you feel that your agent would do, you know, good on your behalf, okay? You can give your agent full control over any decisions that need to be made for you if you cannot speak for yourself. And so if you decide that your agent's going to, you know, be the best person to make these decisions, then you don't have to do that part at all.
I had another question pop up in the chat box. They said, what if how does it work the next of kin in Maryland? If you didn't do an advance directive, then you had the next of kin, how does that work?
Okay, so Maryland has a surrogate law, and the surrogate law says that your next of kin, whoever that may be, whether it would be mother, father, brother, sister, aunts, uncles, cousins, they will go down the line. If there is no family available, they will go to closest friend. They will go to, anybody that knows the patient and it can make those decisions for the patient in the patient's best interest.
Great, thank you.
Mhm. So the living will part, Maryland Part 2 and Delaware has other medical instructions in it, but there is a space for optional goals and values. This is where you can put anything you want into this space, okay? You can put things like, I do not want to suffer. If there's no hope for meaningful recovery, let me die naturally. I do not want to be dependent on others for my care. I value my independence. I prefer to die at home with family close by. Or I value length of life over quality of life. I want to be kept alive on life support. There's things that are put in there like, keep me alive, keep me on life support for 3 days. If nothing happens, then you can take me off of life support, things like that. But you can put anything you want to express your goals and values in this space. So the living will, making end-of-life decisions in certain conditions. You make your preferences known when you're attending and a board certified neurologist or a neurosurgeon certified that you are one of these conditions, a terminal condition, a persistent vegetative state, permanently unconscious or an irreversible coma, an end-stage condition, serious illness or frailty. This was actually added to the Maryland Advance Directive because of Alzheimer's. So there's also Advance Directive form, which is called 5 Wishes, which you can get online, and it's worded a lot differently and probably more easily to follow than state forms are. But it's an option that you can do also.
Thank you.
So the Maryland Advance Directive Part 2 was where you can choose full life support or keep me alive, with certain conditions. It says allow a natural death with or without artificial nutrition, in terminal vegetative state and end-stage conditions. Number one is keep me comfortable and allow natural death to occur. I do not want any medical intervention used to try to extend my life. I do not want to receive nutrition and fluids by tube or other medical means. This is the best choice if you prefer to die at home. If you want to be comfortable, you are tired of being poked and prodded and everything, this is the best choice for comfortability, okay? The next one is keep me comfortable and allow natural death to occur. I do not want any medical interventions used to try to extend my life. But if I am unable to take nourishment by mouth, however, I want to receive nutrition and fluids by tube or other medical means. So you may need to be in a facility to get those, to get that nutrition and those fluids. So it wouldn't be the best if you wanted to be at home, like say with home hospice. Or the third is try to extend my life for as long as possible using all available interventions that in reasonable medical judgment would prevent or delay my death. Okay, so this, some people choose this because most of the time there's a fear there, okay? And that fear takes over and they say, oh no, try to keep me alive. whatever. Well, if you have a terminal condition or an end stage condition, this option would probably make you suffer rather than bring healing and comfort to you.
Sure.
So you have to be very careful and know, like Gigi said earlier, what your prognosis is, what the doctors are saying, your illness is leading to. Is very important for that.
I'd like to add that some family members choose that because they don't want to lose their loved one, but they're looking at it from their own personal perspective. I mean, nobody really wants to lose their mother or spouse, but what's really best for their loved one might not be that option.
Sure.
Exactly. All this, I was going to mention in the beginning and I sort of forgot, but in ICU at one time, I had a 50-some-year-old gentleman that I called because there was a code blue, and I went and they were coding him for the third time. And his wife and his daughter were in front of the room, and they were walking back and forth, just distraught. So I walked up to him, I introduced myself and asked him if I could do anything. And they looked at me and they said, he wouldn't want this. And so it kind of took me by surprise. And I was like, you mean he wouldn't want them to do what they're doing? And she said, no, he wouldn't. She said, this is the third time that they've had to do this, and he would not want this. So I said, do you want them to stop? And she said, yes. So I went and told the doctor, and the doctor come out and confirmed, and then went back in and stopped it. Well, the man passed away, but the level of distress on them decreased rapidly. And it sort of made me champion, the Advance Directive and what it's for. And actually, the Advance Directive is for the comfort side of things, saying that you do not want certain things when it gets to that point where I can't think for myself, and I'm not going to come out of that.
And for that wife and that daughter who were with him during that, and they knew that that's just not what he wanted, that would take a burden off them too.
Yes, yeah. So then there's the signature and witness page. Only the person filling out the Advance Directive can sign it or change it, okay? Even a power of attorney cannot do that. Your healthcare agent cannot be a witness. Anyone who knowingly gains financially from your death cannot witness the document. And some states do require that you have it notarized. Maryland, Delaware, Virginia do not. Okay, and if you frequent a state, if you frequent a state often, then I suggest that you just look on their Attorney General website, and you can find out if they require it to be notarized. A notary can add a page to your document, and then you would be good to go. But most states will recognize the Advance Directive from other states without question.
Great. Great. And what is the difference? You guys talked about a MOLST form. What is the difference between the MOLST, the Maryland Orders for Life-Sustaining Treatments, and the Advance Directives?
So the Advance Directive is a legal document that's signed and can only be changed by you. It's used only when you cannot speak for yourself. And the MOLST is, like what it says, a medical order for life-sustaining treatments. And that is, the orders are placed by your physician, either your primary care physician in the office. He can have a MOLST form, or if you're admitted to the hospital, they have the MOLST form in your chart there. So this discussion would be made with whichever doctor is taking care of you at the time. And this can be changed each time you go to the hospital. It addresses goals of care, and it addresses your code status, which means a code status is whether or not you want to be fully resuscitated and placed on life support, or not. And if you're not, then you would be a do not resuscitate or a no CPR order. And then there's many other treatments that you can have to sustain life or not if you choose not to have different things like dialysis and tube feedings and antibiotics and blood. So you can choose or limit any of these treatments, and you can change your order. You can change the order just based on talking to your doctor and say, look, I was a full code. Now I want to be a do not resuscitate. Or if you want to have surgery, usually they require you to have to be a full code for a short time after surgery to recover. And that's a conversation you'd have with your surgeon. So if my heart stops and I require CPR, what are my chances of recovery? So the more health problems a patient has, like I said, the chronic diseases, it depends on where you are in that trajectory of your illness, the less likely you will recover from your heart stopping. And it depends on how long your brain and your kidneys, whatnot, do not have blood, so that, if it's very quickly, immediately, you might have a chance of full recovery. But if you're already deconditioned or frail or elderly or have an end-stage illness, chances of recovery really are not good. If you have an end-stage disease like a neurological Alzheimer's or Parkinson's, any end-stage condition, the survival rate can be as low as 1%. So CPR was basically designed to resuscitate younger people who have otherwise good health and they have a sudden cardiac arrest. That's what it was designed for back in the 70s. We've kind of, we let everyone have CPR if they need it, of course, but it's not necessarily a good thing. And sometimes in the frail and elderly, it can be a little traumatic and harmful. I know that I've done CPR on elderly, frail people before, and it really felt like I was hurting them more than anything. So it also causes moral distress on the caregivers. Knowingly doing something that's painful with no benefit kind of makes it hard to think that I'm doing a good job.
Sure, absolutely. So what should I expect if I were to receive CPR?
So you can expect compressions, and they're pretty deep. The television, when they show it on TV, is not like real person. It's pretty violent, and there's lots of caregivers at the bedside putting things in you, tubes and ventilators, tubes in your throats, tubes in your neck and in your thighs. It is definitely a procedure that takes a lot of people to do, and I don't think a lot of people appreciate that. The lay people who've never seen it or experienced it. And like John said, once the family saw what they were doing to their loved one, they thought again that maybe that's not the best thing to do in this situation.
Right.
And if it's a trauma and it's a young person, and it's a great thing, we can bring people back. But if you have like a chronic disease or an end stage condition, it's not always, it can bring more harm than good.
Thank you.
So there were some polls done around preferences around prolonging life. And it looks like most people prefer to allow natural death if their heart stops or they stop breathing, especially in an end stage condition. About 5 to 10% of people would want to be placed on life support. And some of those people say they would like to try it for 3 to 7 days and then have their families decide after that. About a third are unsure. And by default, if you don't plan or you make your preferences known, you will get all those treatments. The CPR, the dialysis, the ventilator, all kinds of things that you may necessarily would not have wanted, but you didn't make your wishes known. And there's a tipping point when continued aggressive therapy can impose more suffering than the disease itself. causing more harm than good. And we see that a lot in patients who are constantly in and out of the hospital. We're not making them better. We're really just kind of maintaining, but it's, it affects their quality of life. So it's interesting. Like I said before, the more you know, the better decisions you make. And I think a lot of healthcare providers, or most healthcare providers, would choose a do not resuscitate for themselves and their loved ones if they had a terminal diagnosis. More than 80% of Americans say that they would not want intensive treatment or even hospitalizations at the end of their life, but they don't clearly communicate these desires. So more important to speak with your family members and your providers to make your wishes known. And what happens if I don't make my wishes known or plan ahead? You get all the above. You get the full treatment, no matter what. Even if you're in an end stage condition, even if the doctors think it's probably not a good idea, they can kind of suggest it, but in the moment, they're going to just go for full throttle, full code. So you're going to get all the aggressive therapies. And this is my experience with some elderly patients who were dropped off at the ER during COVID, who had like dementia, not terrible dementia. They could still walk and talk, or they couldn't hear. And they get asked, do you want us to do everything for you? And they nod yes. And then their code changes from a no CPR to a full code. But then we have to clarify that later when they see their primary care provider. So communication is key.
Absolutely. And it's so easy somebody said recently, it's so easy to sign up to be on a ventilator, but it's really hard for the families to decide to remove that and when to remove that and how that makes them feel. So it's just so important for people to make that really as a gift for their families, to not have to decide that later on.
Yes, when there's been a documentation or patients have said something like, I wouldn't want to do that, I wouldn't want to have that, that at least gives them comfort to know that they're making the right decision for their loved one.
Absolutely.
So this quote by St. Francis of Assisi, while death is dreadful and a real ground for fear, there are things worse than death. And I think when patients are in the ICU getting a lot of treatment that, most of the providers agree that aren't going to get them better, it is kind of almost worse than death. It would be much more comforting to know that this person is going to be comforted and given pain medicine and not go through so much therapies that is detrimental to them and their families.
Absolutely. So what are my options?
So early in your disease process, you're newly diagnosed with cancer, you're going to probably choose aggressive therapies like chemo and radiation, even if it causes a lot of suffering, because the benefits will hopefully outweigh the burdens. You can put up with a lot of side effects knowing that there's a possible cure. But as you age or your diseases progress to end stage, you may focus your goals, and your goals of care may change. You can continue aggressive therapy with the goals of reducing pain and suffering and having a good quality of life. When that tipping point happens and it's more burdensome, you can opt for less aggressive therapies and focus on comfort and quality of life. You can stop all treatments that are burdensome and just opt for comfort care. You can also change your mind at any time. These are not written in stone. You can choose one thing and then change your mind and speak with your providers to see what other options there are. So this is fluid communication back and forth between, your care provider and yourself based on your needs and values and goals.
One of the things that I wanted to point out is when it comes to advanced directives and the MOLST is that an advanced directive, is done sort of for the future. The MOLST is for the here and now, and they do not have to match. If, for instance, myself, my advanced directive says to keep me comfortable and allow a natural death to occur. I don't want any interventions if I can't think for myself, and I'm not going to come out of it. My MOLST, however, I want them to do CPR now because I'm fairly healthy, and I want them to try to revive me. Okay. So they don't have to match, but if you have a terminal condition, an end-stage condition, at some point they will need to match so that you don't suffer along the way.
That's a very good point. The MOLST is here and now, and Advance Directive is advanced for the future.
Yeah.
So palliative care is an option. Providing palliative care, defined by the Center for Medicaid and Medicare Services, means providing patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. So whether it's pain or other suffering. So using palliative care throughout the continuum of an illness, in the beginning of an illness, like something like cancer, you can address the physical, intellectual, emotional, social, and spiritual needs. They help, the palliative care team helps facilitate patient autonomy and access to information and choices. So a palliative care team helps patients and families establish goals of care when they need to be talked about, and helps patients and families discern when to change the focus from curative to comfort. And palliative care is given alongside curative treatment or aggressive therapies.
Great.
So what is comfort care? So comfort care is defined as patient care plan that is focused on symptom control, pain relief, and quality of life. It's typically administered to patients who have already been hospitalized several times for the same end-stage condition, with further medical treatment unlikely to change the outcome. Home hospice should be considered at this time. If a patient says, I really don't want to go back to the hospital again, this is a good time to have this conversation. So when goals of care are quality of life and comfort, and you and your family have made the decision to not continue aggressive treatments or to re-enter into the hospital for more treatments for that end-stage condition, you can consider home hospice. This does not mean you are giving up hope or that death is imminent. Some patients live many months after their hospice diagnosis, and you are entitled to elect this hospice Medicare benefit if you meet the requirements. The hospice team consists of a provider, either a nurse practitioner or physician, a nurse, a chaplain, social worker, and even a healthcare aide. They all care for you and support you and your family in your home, and their goal is to help you increase quality of life and reduce your pain and suffering. I like to say it's a great benefit that's covered by insurance that many people don't take advantage of.
Absolutely.
So what is important when you get closer to the end of life? Most people don't want to be in pain. So physical comfort, a lot of people have anxiety and shortness of breath with some of their diagnoses. And hospice can help with all of these. There's mental and emotional needs like depression, worries, and fears. There's spiritual needs like finding the meaning in your life and ending disagreements and healing relationships. And your hospice team has special training to help you guide and address these needs. A lot of people have fear around death, and hospice is the best team to help patient deal with fears regarding end of life. So advanced care planning helps your healthcare team provide individualized care. Not everybody wants the same care, especially nearing the end of life. Your providers want what is best for you in your unique situation. They can provide the best treatment for you when they know what is most important to you. You have choices as to how aggressive you'd like your treatment to be. Your goals of care may change over the course of your illness. Knowledge about your disease progression and the natural dying process gives you and your loved ones some control in your plan of care. We don't always have a lot of control in our life, and the healthcare team has has a lot of control over what happens, but this is somewhere where you can have some control.
Absolutely, absolutely. Besides primary care providers, is there anyone else that can help with creating an advance directive?
So your family lawyer, your primary care physician, your pastor or faith community can help you, a nurse care coordinator, which is what I do in the primary care offices. And of course, John Tyler, he's a chaplain at Tidal Health. Yeah, I mean, we all believe it's important, and just reach out to any one of us to help you fill these forms out, or just have conversations with your family members.
Thank you.
And remember, not talking about advanced care planning can make it more difficult for your loved ones who may be left wondering what they should do in certain situations.
Thank you so much. Thank you, Gigi. Thank you, John, for all this wonderful information. It's so good to know. It's so important, and we learned so much today. If there was one piece of critical information that you both want us to take away from this presentation, what would that be? Gigi, I'll start with you.
So you're able to make better decisions regarding your care when you are nearing the end of life with accurate information and understanding of your disease and the natural dying process. We want to make sure we abide by your wishes to maximize comfort and reduce suffering.
Thank you. Thank you. And John, how about you?
I would have to say that the peace that it brings to individuals and their families, knowing that they've already made the decisions, they don't have to make them, they don't have to go through the anguish and the distress of not having it.
Absolutely. Absolutely. Takes a big pressure off of them for sure.
Yeah.
Well, I want to say thank you to our panelists, Gigi Pierce and John Tyler from Tidal Health, for helping us learn more about advanced care planning today. And thank you to everyone who has joined us. We hope the information was useful to you. We have a great list of references prepared that we will send to all the attendees on this today. To wrap things up, we ask that you take a couple of minutes to fill out the short survey. It's only 5 simple questions. Your feedback will help us bring relevant programs to you, your practice, and those you care for. When you click Leave the Meeting, you will receive a survey from Zoom. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you can call us at any time on the number on the screen. Thank you once again for joining us. I'm Lauren Blair, and have a wonderful rest of your day.